We just wrapped up what might be the single most important interview we've ever done on the Catalyst Health, Wellness, Performance Coaching podcast. So with Dr. Martin Kulldorff out of Harvard. He's a biostatistician and epidemiologist, and he was highlighted in the Wall Street Journal with a full page spread last weekend talking about COVID, the realities, what we're missing in the headlines, the practical aspects that we need to understand. So I reached out to him. He was kind enough to jump on with very short notice. And it's a fascinating discussion. So helpful personally to me, answered a lot of questions that I've been struggling with, and I hope it's the same for you, your family, your friends, your coworkers, etc. So again, this is the unedited version. It's something we want to get out ASAP here on the YouTube coaching channel for our subscribers. If you're not a subscriber, that's an easy way. If you click that button to tell us you like what we're doing. The edited standard audio version will be out on the Catalyst Health, Wellness, and Performance Coaching podcast in about a week, but we want to get this thing out ASAP, and we hope it's helpful. So let's jump into this interview. Fascinating, fascinating stuff. I hope you enjoy it and find it helpful as well. Thanks, everybody. Dr. Martin Kulldorff, thank you so much for joining us today. Short notice, very important topic, and we're really grateful to have you join us.
Thank you. It's a great pleasure.
So obviously, we got a little controversy we're talking about today. Let's talk about why there is such a controversy. We have bright minds, some of the best scientists in the world on both sides. Why is there? Why can't we get the answer figured out? Why can't we have something for the public where this is what we need to be doing? This is what the government should be going. It just seems like we're on these two different sides of the coin. Any general thoughts about why there's such a span here going on?
So it's not an easy question, but the way I interpret it is that there are basic principles of public health that has been thrown out the window.
Yeah.
And one of them is that we can't just look at this short term. When you look at public health, you can't just look at it short term. If you're a physician and you're treating a cancer patient, then you look at it short term because you want to extend their life by another 6 months, another year, so they can spend more time with their children and grandchildren.
Right.
But in public health, you have to look long term. That's the key principle of public health, and we have failed to do that. If you look at the newspapers or media, they look at what are the current case counts in this country or this region and compare it to the next one.
Right, huge attention.
That's sort of like judging a marathon based on who is leading at the 5 kilometer mark.
Yeah, good comparison.
So, and the second principle that we have ignored is in public health, you can't look at a single disease. Again, the oncologist treating the patient, well, they're focusing on that particular cancer. Other things also, but that's the focus where you treat that patient because that's the disease the patient has. But in public health, you can't just focus on one disease, COVID-19. So with the countermeasures and the lockdowns, there has been enormous collateral damage on other aspects of public health. Childhood vaccination rates have plummeted. Cardiovascular disease outcomes are much worse. People don't get to the hospital in time and they might die at home. Or the prevention measures are not there because they're not going to their primary care physicians. Cancer screenings are down, so we are detecting less cancers now. That's not because there's less cancer, it's just that we're not detecting it. So that somebody who maybe didn't get their pap smear, she might now die 3 or 4 years from now instead of 15 to 20 years from now. And of course, that doesn't show up in the statistics this year, but it's still something that we're going to live with and die with for many years to come. The mental health aspects, I think, are horrendous. What the lockdown has caused for that. So, and of course, the other diabetes treatment and all of those things. So there's enormous collateral damage. Also, when there's house evictions, that's not good for public health. And if, as scientists, we need to view things global and internationally. So if we look at it in the developing world, in Africa and Asia and Latin America and so on, there are children who are starving to death because of the lockdown. The parents cannot afford to. Parents who live day by day, getting the income to buy the food for that day, they cannot afford to feed their children. There are people from the cities who have been forced to walk home many, many miles to get home to the village because the rug was pulled out of them in the cities, and some making it and some not making it home to the villages. So there's the collateral damage that has been caused due to the lockdown has been enormous. And you have to look not only at COVID-19, you also have to look at all these other aspects of public health.
So great points across the board. And why is that getting missed? Why are the scientists that are saying, no, lockdown is the answer? This, and it seems to be tilted that way, as you're well aware from the pushback that you're getting. Why are they missing these two core aspects of public health analysis?
So some scientists are completely missing it, and I don't understand why, because to me, it's not rocket science. But I think most scientists, or at least the majority of the infectious disease technologists that I know personally and that I talk to personally about these things are in agreement with me that lockdowns are not a good thing. It was good in the beginning to flatten the curve so as not to overburden the hospitals.
Right.
Because you don't want everybody to go to the hospital at the same time, because you can't take care of it. So some form of such measures was needed in the spring for a short period of time. But among my colleagues that I talked to, the majority do not agree with lockdowns and think that we should have a focused protection where we have to do a much better job protecting older people who are at high risk, while letting children go to school in person. There's no public health reason why they shouldn't, and letting young people live close to normal lives. They should wash their hands and those kind of basic things, but they should. There's no reason to do a lockdown for young adults. And everybody knows that there's a difference in risk by age, but it's not just like a 2-fold or a 5-fold or a 10-fold. It's not even a 100-fold difference in risk. While everybody can get infected, there's more than a 1,000-fold difference in the mortality risk of death. So for older people, COVID-19 is a very serious disease and dangerous, and they have to take precautions. And as a society, we have to help protect this group. But for children, COVID-19 is less dangerous than the annual influenza. So for children, this is not a dangerous case. They will get infected. And if you start testing people in schools and colleges, you can have a lot of positive cases for sure. But this is not a dangerous thing to children. And I have an 18-year-old son, and I'm much more concerned about him driving than about him having COVID-19.
So okay, let's stay on college kids for a second. We've got so many colleges that they're starting class and then they're taking a 2-week break, or they're in the fall or in the spring, they were sending kids back home to, in my mind, infect other people that maybe were at risk.
Exactly.
What is it? Just protection? Is it just the administration feeling like we have to do this because it's what everybody else is doing, and we can't be the one school that? Any thoughts on that? Why is that happening? It seems like with the data that you're providing, that the risk factor is so low that the concern wouldn't be there. They would just be, hey, we're in a somewhat protected area. We're able to move forward. Let's not then send these kids back to grandma and older parents and those folks. Any extrapolations on that?
You're 100% correct. And maybe there's some herd thinking going on here. But closing universities and colleges is actually damaging for public health, because as you say, if they're at college and if they infect each other, that's not a public health concern because they're not at risk. The risk is minimal. The older teachers, the older professors, if you have professors that are older than 60, they have to be protected. So they should, I think, do online teaching. The students could still go to the classroom, and maybe there's a TA there in the classroom with them so that they can do the collaborate and socialize and sort of interact between the students. But all the professors over 60 should do online teaching. But other than that, the university should operate normally. And to send children home to their families, some of them have parents in their 60s and so on, and they're not going to sit in their room all the time.
Right.
They shouldn't. That's unhealthy for them. So it's actually bad for public health to close the universities, and it's of course also bad for the students because they need a better education with in-person teaching, but also it's good for their mental health and their social life. So I think it's there's no public health reasons. And another problem is that the universities are testing the students when they come to the universities.
Right. Which they already have it at that point. Like, what good is that doing?
That's nonsensical.
Right.
If they are sick, let them stay in the dormitory room until they get well, if they have some symptoms or whatever, if it's COVID or not. But on the other hand, where it makes sense to do the testing is actually before they go home again.
Right.
Before they go home for Thanksgiving or Christmas, when they're going to actually meet their parents or their grandparents or aunts and uncles. That's when actually it makes sense to do testing, not when they come to the universities. Right. So it's sort of backwards.
And again, I know you don't know the answer to this, but I just don't get why. Why is this happening? Because that's the pattern across all. We have kids that are also college age, 20. Actually, one's a 5th grade teacher. So 2 in college and 1 is teaching the younger kids. And it's exactly what you described. Why is this happening?
I don't know.
You're like, I'm trying to change it, Brad. Yeah.
Yeah. I mean, when I tried to speak out, and many others in March and April, both me and many other scientists, that we should do a different approach, we had a very difficult time to be heard. I tried to publish and I was rejected by both the regular media as well as more scientific-oriented media. I was able to publish 3 op-eds in the major daily newspapers in my native Sweden. So that was not a problem, but in the US, I was unable to publish anything.
Interesting.
So there was some kind of reluctance to have an open scientific discourse on these matters.
Which is stunning because that's what the research is there for. The scientific method is put it out there, get it reviewed. It seems so counterintuitive to the way it's supposed to be.
Yeah, that's how we have done science for about 300 years now, since the Age of Enlightenment started. So I think it has actually worked quite well for us during those 300 years.
Hello. Exactly. Huh. All right. So let's talk about, for people that want to look this up in more detail, it's called the Great Barrington Declaration. I can't say your co-writer's name correctly. Is it Bhattacharya?
Yeah, Dr. J. Bhattacharya from Stanford University.
And Dr. Gupta came out against lockdowns, economic restrictions. You focused on, you talked about focused protection for those at minimal risk. Now, 2 questions about something you said earlier. You said kids are not at risk. Is that up to age 12, 14, 16? Is it the college kids? Is it 30? Kind of where does that, and I know there's not a blanket lockdown specific answer, but is there kind of a general trending that up until, is it literally up to 59, or is it, the curve continues to progress as you age after age 20 or 27 or something like that?
Yeah, so first of all, we have the difference between risk of infection and getting sick and risk of mortality or have serious things. So risk of infection is across all ages.
Sure, absolutely.
Many of the young ones will be asymptomatic. They'll still get infectious, but they will be some will have mild symptoms and some will be asymptomatic. So the difference in risk by age is really in mortality and serious complications. And it's a gradual thing. So if there's no cutoff where suddenly you're at higher risk, it's a gradual thing that is, if you're in 60s, I think you're at sort of high risk, but it's much less than actually if you're 70s. And in the 70s, you're actually much less risk than in the 80s. If you're below 50, you're at low risk, but those in the 40s are at slightly higher risk than those in the 20s or 30s.
Okay. So gradual.
So it's sort of a gradual thing,
Yeah.
And no cutoff.
And then let's chat just slightly about this age thing. We have a lot of masters athletes that listen to this show, and they know that there are plenty of 50 and 60-year-olds that are far fitter, far healthier, et cetera, than frankly a lot of people in their late 30s, early 40s. Is that 60 number just, we had to pick a number somewhere, it's a generic thing, or should we be looking more at risk factor versus chronological age? You know, if you have a 60-year-old who's I don't know, a fit triathlete, are they at far less risk than the 40-year-old who's got diabetes and is smoking and some of those kinds of things?
So that's a great question and a very important one. So age is by far the major risk factor, which sort of makes everything else much, much less important. So age is by far the biggest risk factor. But there are risk factors also for example, obesity and diabetes. And we don't know the exact estimates for those, but it's around a twofold excess risk if you have these risk factors. So that means that somebody who is 50 years old, who is obese and diabetes, might have the same risk as somebody who's maybe 60 years old without those things.
Okay.
So those risk factors maybe is about 5-10 years, corresponding to about 5-10 years of age. So even if you have these risk factors and you're in your 20s, you're still very low risk.
Oh, interesting. Interesting. Okay.
But it is something that needs to be taken into account, because maybe I said a professor or teacher at schools, if they're over 60, they should do it home. But if they are 55 and obese and have diabetes, they should probably be moved into that category as well.
Right. Okay. Very good. All right. So
this also means that one of the things that we can actually do to reduce our own risk, and if you haven't done it before, this is a perfect time to do that, is to exercise more and live more healthy lives.
Yeah.
So don't sit inside at home in front of your computer because you think that is the safest.
Right.
Go outside, go walking, hiking, running, bicycling, so move around in the parks or in the forest or wherever, or just on the streets. That is a healthy thing to do. And of course, eating healthy is always important, not just for COVID, but for everything. So if you ever were thinking about when to start to move into a more healthy lifestyle, I would suggest that 2020 would be a good year to do that.
Yeah. Excellent point. Excellent point. All right. So let's dig into the Great Barrington Declaration. Can you start us off by explaining exactly what would this look like in practical terms?
So there's two components of it. One is to do a better job protecting older people and other high-risk groups. And the other one is to remove the lockdowns and let children and young adults live near normal lives. So if you start with the high-risk groups and the older, there's sort of roughly four groups there. Those at highest risk, both because of age and frailty, are the people living in nursing homes and similar places. They are absolutely at the highest risk. And we have done a terrible job protecting the nursing home residents. Not across the country, but in many parts of the country. It's been very tragic. So what we have to do is that the first thing is, unless the staff has already had COVID so that they're immune, they need to be tested frequently to make sure that they don't bring in the infection into the nursing home. And it's much more important to test the staff than to test the residents. There's no harm in testing the residents, but the most important thing is to test the staff. And if transmission is very high in the community at the moment, it has to be very, very frequent testing. If it's less transmission in the community, maybe once or twice a week would be enough. The other thing, nursing home residents needs to have visitors from family and friends. That's an important part of their, not just their social life, but for their physical well-being, to have those kind of visits. So we need to be able to arrange so that family members can be tested and visit. So there are these tests now that can be done, and you get the results the same day. So that's very important. And if you're visiting your grandfather and you happen to test positive, well, then you should wait and visit him 3 weeks later instead. And maybe your sister or cousin can go visit this week instead. So that's the second thing that's important. The third one is to minimize staff rotation, so that the same resident don't meet 20 staff person during a week, but maybe only 4 or 5. Because the fewer there is, the less the risk of transmission. And then, of course, we have to make sure that when new residents enter a nursing home, they have to be tested also. And you cannot do as it was done in, for example, New York and New Jersey and Massachusetts, that you send sick COVID-19 patients back to the nursing homes, who then infecting the other residents of that nursing home. You absolutely cannot do those things. So those are the key aspects for nursing homes. And I know, for example, Scott Atlas, who has been pushing very hard for those things. I think very good. So we're doing better with the nursing home now than we were in the spring, for sure. But there still has to be better protection. The second group is those who live at home, but who are retired people. Maybe they live by themselves, or they live with a spouse or somebody else. So for them, it's important that they, of course, also have to see family and friends. So we should help with testing for that also. But it might not be the most important thing to go to the supermarket. That might not be the most important part of their life. So there we should make it possible to have groceries and other essentials delivered to the home. And when I go to the supermarket, I still see old people there. And we should do a better job helping them with those things. And also, when they meet family and friends, it's good to do it outdoors rather than indoors as much as possible, just to minimize the infection risk. A third group are those over 60 who are still in the workforce. And if they can, as much as possible, they should work from home. But there are some who cannot work from home. And then we need to find a way to offer them to do a sabbatical for a few months, like 3 or 4 months.
And this is just the high risk group that's in that.
Yeah, those who are above 60, I would say everybody who's above 60.
Okay.
And not for a long time, because if we do this focused protection, we're not going to drag out this pandemic for a long time. It will be over much sooner. So while there's high transmission in the community, like 3 or 4 months, we should offer them some kind of a sabbatical. For example, we could say, well, you can actually use some of your Social Security funds now instead of later. And that we will cover you for these 3 or 4 months if you have to be home. So that's sort of a practical way to do it.
Right.
The fourth group, which is actually the most difficult one, are those who live in multi-generational homes. And there was a study out of Stockholm that showed that if you're above 70 and you live with somebody about your own age, who is not in the workforce, compared to if you live with a family member who is below 65 and in the working age, then those who live with, which could be it could be a younger spouse, but often I think it's a child, a son or a daughter who is working. Those who live with a working age adult are about 60% higher risk of COVID compared to those who live with somebody who is their own age. So there is an increased risk from these multi-generational homes. So they're the solution. But interestingly, actually, if you also live with a child, typically a grandchild less than 16, then you're not in any additional risk compared to only living with your working age family members. So the children are not the ones that are putting a risk to these older people in multi-generational home. It's the working age adults in those whole households that are generating the excess risk.
I'm not completely following this. So it seems like just mathematically, if I'm 70 and I've got somebody who's 45 out working, and then I also have a grandchild who's 12 going to school, aren't you bringing in more variables into the equation by doubling that potential?
No, so the interesting thing is that living with a 45-year-old is increasing your risk by about 60% compared to if you were living with somebody who was 75, like your spouse or something. But if you live with the 45-year-old as well as the 12-year-old, the 12-year-old does not increase the risk any further compared to only living with the 45-year-olds. So the risk doesn't come from the children, the risk comes from the adults. And there is a biological explanation for that, which there was an interesting study from Iceland where they looked at the genetic of the viruses. So they could actually track who infects who. So they found that adults will often infect children, but children will very seldomly infect adults.
Really?
It can happen,
Sure.
but it's very rare.
Interesting.
So and that's different from influenza, because for influenza, the kids
bring it home.
Yeah, they are the ones, and schools are sort of a driving force behind the influenza epidemic every year. But COVID operates differently.
Interesting.
So it's not so if you're 17-year-old, you should be afraid of your sons and daughters, but your grandchildren are not as dangerous.
Interesting. Interesting. So a little quick sideline here. You made a mention that if you've already had it, you're immune. I know there's some different studies saying different things along those lines. I know we don't know, so I'm not asking you to put your name on paper here, but from your greatest knowledge, if you've had it, are we thinking you are immune, or are you immune for a certain time period? Do we have any insights into that at this point?
Yes, we do, and there's been a lot of confusion and misinformation about it. If you've had it, you're immune, period. There have been a handful of cases where there has been a second infection, but it's very, very few, and almost all of them has been very mild. So considering the millions of people who have been infected and have had it, with so few getting it the second time, it's very clear that we have immunity to COVID-19. Now, that's the first part of the answer. The second part, how long does the immunity last?
Right.
So for some viruses, if you had it, you're immune for the rest of your life. For other viruses, you're immune for a certain period of time, and then the immunity wanes. For COVID-19, we don't know which category it is for obvious reasons. My guess is that, and this is just a guess, but is that it does not last for the whole life. That would be my guess for COVID-19.
And is your guess that it does give us a year, or it's too early to make even any kind of assumptions?
Well, we know it gives at least for half a year and more. So for the vast majority. So yeah, I think it will last for several years.
And it seems I've seen some headlines about people are getting it a second time, or it seems like there was a study out of the UK a couple of weeks ago that the antibody levels had dropped by 30% from what they were originally in these folks. Am I missing some key data into this?
Yeah, so there's a confusion about antibodies and immunity. So antibodies is one form of immunity, and that study that came out, I think last week, was nothing really new, because we knew from before that antibodies goes down with time after you're infected. But that doesn't mean that you're no longer immune, just because you cannot detect the antibodies. And as I said, there has been very, very few reinfections. They make the news, but they are very, very few.
And when you say very few, we're talking less than 1%, less than 0.5%, something like that. I mean, is it minuscule, or is it just not?
Minuscule, less than 1/10%, less than 1/100%.
Interesting.
It's minuscule.
Okay, super helpful.
And also, in addition to antibodies, not everybody who are infected produce antibodies. because we also have T cell immunity. So there are different forms of immunity. It's a complex system. So there's also other forms of immunity. So when, for example, somebody says that 10% of the population have antibodies that are detectable, that doesn't mean that it's only 10% that are immune. It means that at least 10%, but it's more. We can't measure how much more, but we know that it's more than 10% that have immunity.
Right. All right. So that leads in really nicely to this idea of herd mentality, which I know you said makes people think about mass murder and these horrible things. How does that actually play a role? What does it really mean? Help us understand this concept, and how does it fit into your broader recommendations?
So you're asking about herd mentality?
Herd immunity.
Herd immunity, yeah.
Yeah.
So that's probably the most misunderstood term of 2020.
Mm-hmm.
And as a scientist and epidemiologist, it's sort of stunning to observe, because herd immunity is just a well-proven scientific phenomena, just like gravity in physics. So to discuss whether herd immunity exists or not, that's like discussing whether gravity exists or not. And there are a few ways to also, whatever strategy we use for COVID-19, we will eventually reach herd immunity. That's unavoidable. And that's just like many other diseases. That's sort of the natural end state of a pandemic. And COVID-19 is not a disease that can be eradicated. It will, even after the pandemic is over, we will enter an endemic state where it will still be in the population, but not many people will die from it. Just a few people every year. So it will never disappear completely, but because of herd immunity, that's what sort of ends the pandemic phase. And it means that the pandemic will end before everybody gets infected. So 100% of us are not going to be infected. Only a proportion of us will be infected, and then the pandemic will be over. So that means that we have a sort of a choice. There are certain people who, whatever strategy we use, are going to go and get infected. There are other people who will not need to get infected. So how many people do we put in each of these groups? Well, if we do nothing, if we do no countermeasures, what's going to happen is that some old people will get infected and some young people. Some old will not and some young will not. And since a fair amount of old people are getting infected, we're going to have a higher mortality because they are the high risk. Now, if we do lockdown measures that are across the board age-wise, so we protect everybody equally by age, then we are pushing things forward, but eventually people are going to get infected. So again, we can have some young people infected and some old, some young people not infected and some old people not infected. So that means again that there will be a fair amount of old people getting infected, and while it will happen later, there still will be old people who die because they're high risk. On the other hand, if we do focused protection, what we're doing is we're trying as much as possible to protect the older people. So we are minimizing the number of older people who are in the infected group. It can't be done 100%. That's impossible. But we are trying to minimize as much as possible and maximize the number of old people who are in the group who are not getting infected. And that's how we minimize the total mortality from COVID-19, by protecting those older people.
And where does the vaccine fit into this whole equation? Let's assume we've got one by next spring, March, April, something like that, that's actually effective and available. How does that fit into this broader strategy?
So when it comes to herd immunity, one can achieve herd immunity either through natural infection, which is sort of the process we're currently in, where more and more people are getting immune, or we can get herd immunity through a vaccine, which is, for example, how we now have herd immunity for measles, or we can do it with a combination of the two. So either of those, that's how we reach herd immunity, and the best way to reach it is obviously through a vaccine, or a good, effective and safe vaccine. Now, we don't know when the vaccine will become. There are enormously good work trying to develop vaccines. Not all of them are going to work out, I think, but there are hopefully some of them will, and we will hopefully have a vaccine. And when we do have, that has to sort of play into the focus protection plan that we prioritize the high-risk groups for getting the vaccines. That is the older people, as well as healthcare workers, because they also are high risk because of potential exposure, higher risk for exposure. So, so getting a vaccine sort of fits in as one additional measure to use for this focus protection.
Okay, so let's go broad here. So many headlines, people can't stop reading about this stuff. It's the leading news story every single day. Any clarifications you'd like to put out there for people that they really want to understand? They don't want to just follow the, whoever wrote that headline that may not be a scientist, may not understand what's really happening here. Are there some headline busting clarifications that you can provide us where you say, now, remember, when you hear this, it actually means this. When you hear that, they're leaving out this other key piece. Any of those types of things that you could help us to read between the lines, if you will?
So I think that if I could change only one thing with our current approach, it would be to open all the schools for in-person teaching.
Interesting.
Immediately. Because I think that the collateral damage on our children is very serious. They need education. And school is not only important for that, it's also important for physical health, for mental health, and for social development. And obviously, the school closings are affecting working class children the most, because children in more privileged families, they can afford to put them in a private school or having a pod school or hire a tutor, etc. So it's really the working class children who are affected the worst by the school closing, and it's something that is going to have ripple effects for many years ahead, including into the adult life. So if there's one thing I would like to change, that's it. And it's important then to look at, because people are scared of it, and they shouldn't be, because we should look at it scientifically. And there was only one major Western country who did not close the schools during the height of the pandemic in the spring, and that was Sweden. So in Sweden, all the daycare and schools were open for full day, full-time, in-person teaching from ages 1 to ages 15. And there are 1.8 million children in this age group in Sweden. And during this time, there were exactly 0 COVID deaths among these children. So wow. Children are not at risk. And there were a handful of hospitalizations, but they all came out well. So again, this is not a serious disease for children, and it's less dangerous than the annual flu, which in the US actually kills between 200 and 1,000 children every year in the US. It's very tragic. So COVID-19 is less dangerous than that. Also, if you look at the teachers had the same risk of COVID as the average of other professions in Sweden. So the teachers really? Are at exceptional risk because they are teachers, and they're actually at more dangerous from the fellow teachers than they are from the children. So if you wanted to do protections in the schools, you should sort of keep the teachers away from each other, but let them work with the children. And this results in Sweden was accomplished. They did do some safety measures in schools. for example, they increased the cleaning in schools, surfaces and stuff. A child who was sick for any reason, they didn't do testing, but any child who was sick had symptoms were told to stay home, and if they showed symptoms in school, they were sent home. Also, they didn't do any school-wide gatherings of a few hundred kids. So they kept it to the classrooms where there were like 20, 30 kids in each classroom. So those were the measures that were taken, and there were no masks used in the schools in Sweden.
Oh, really? Interesting.
There were no social distancing. The classroom was set up the normal way. They were allowed to play. They were allowed to play on the playgrounds, sort of just like kids normally do. So the kids had a very normal life.
Wow.
And despite of that, there were 0 COVID deaths among the children and no excess risk for teachers compared to other professions.
Yeah, you talked about the grandchild, child to the 70-year-old, all within the mixed home. I think you mentioned a genetic component to the spreading it. Why are the teachers at less risk with the kids, where they might have 24 of them at one time, versus co-workers, other teachers who might be 3 of them? How does that? What is going on there?
So for some reason, and I don't think we know why, but for some reason, children do not infect others in the same way as adults do.
Huh. That's fascinating. And the numbers that you share, the 1.8 million students in Sweden and no mortality, not a small number, not 20, 0 out of 1.8 million. Why is this not being, I know you're trying, but why is this not being talked about? Like, how is this being missed? That's incredible data.
It is stunning, because as a scientist, if you want to know if smoking is bad or not for you, you have to look at smokers who are exposed. Okay. If you want to know if a vaccine is good or not, well, you have to look at people who got the vaccine and see if they got less sick. That's what we do in science. If you want to know how something affects your health, you have to look at those who are exposed to that thing. So in terms of schools, Sweden was the one country, or the one major Western country where they were exposed, in the sense that they had in-person teaching. So that is the obvious data to look at. That's the most valuable, most reliable, most important data. But when this summer there was an article in New England Journal of Medicine talking about schools and whether they should open or not, and that didn't even mention that study that had come out from Sweden about the schools, even though that's the best scientific information. So even one of the best scientific journals, medical journals, sort of completely ignored that information. And I think it's just baffling that science would operate that way.
All right, and we got to be responsible with your time here. A couple more questions and we'll wrap this up. So your personal advice, you're in Massachusetts, correct? You're there at Harvard?
Yes, yeah.
So if a friend came to you, they're under 60, and they said, I guess they're a friend, so let's say, Martin, we won't go with the Dr. Kulldorff on that case. And they say, hey, Martin, I'm trying to decide, do I go out to eat? I'm under 60. I don't have major risk factors. Should I go out to eat? Should I spend time with, 6, 7, 8 friends who I don't know what their stuff, or would you say, no, don't push it here? What would be your personal advice, or what advice would you implement for your own life in things like eating out in an indoor setting, not a crowded one, but an indoor setting? Some of these different things, going to sporting events where it's spread out a little bit more. What would your personal guidance be?
I try to live as normally as possible. And I try to have my children live as normally as possible. So I think if you're 50 years old or 40 years old, going to a restaurant is fine. I like sitting outdoors, but I will stop doing that when it gets too cold. But I generally like sitting outdoors, so I do that. I think I go see friends if they want to see me. Not all of them wants to. Because they are afraid, but
sure.
those they do, I will meet, and I've encouraged my 18-year-old son this summer, for example. He was out playing basketball with his friends. I encouraged him to do that, hang out with friends. So I think if you're old and if you're 20 and 30 years and you want to go to the pub, I think you should do that. That's perfectly fine. You should be careful when you visit your grandmother, and I think it's good to take a test before you do it. Or if you can't, try to meet outside where it's less risky. And don't invite your grandmother to go to the bar with you. She should stay out of the bar.
Fair enough. Fair enough. That's super helpful. Anything else that you'd like to put out that I haven't asked the right question? We've missed something key that you'd like to get out there to everybody just as we kind of wrap this thing up.
No, I think you've asked very good questions. It's been a great pleasure talking to you. So thank you.
Yes, thank you for taking the time. Hugely important, and we really appreciate you making this happen.
Yeah, thank you.
Take care.
Appreciate you.